Gentlemen, thank you. That was excellent. We're not going to show cases just because we're running a little bit late, so we'll just ask a few questions. Come up to the microphone if you have one, and I'll come up and I'll get started with Tyrone. Tyrone, I'm having a mitral valve repair by you tomorrow for bileaflet prolapse. Straightforward, bileaflet prolapse.
Say again?
I'm having an operation with you tomorrow for straightforward bileaflet prolapse.
Yes.
All I want to know is what's my freedom from a reoperation at the next 15 years?
95%.
So it's better than your papers because you're a better surgeon.
No, my paper's 94 to 20.
Yeah, but let's call about 4 plus MR. How about 3 to 4 plus MR?
No, that's more. That's 65%.
But you've gotten better over time.
We put more Gore-Tex, so I think particularly on anterior leaflet.
Yeah.
We used to prepare anterior leaflet 1 or 2 Gore-Tex only. We put 8 or 10 now.
Yeah, so your data is 65.
We have a paper coming up. You abolish the risk of reoperation.
Yeah, your data is 65, but I'm telling you, you're going to tell me it's going to be better than that now.
Of course.
Yeah, that's my point. You have a question?
Yes, please. Congratulations for all the speakers. Pablo again, Tironi. You don't mention the measure of the coaptation. I think today for a good repair need a good coaptation after the repair, more than 6 millimeters. And easy to do, easy to measure the coaptation in operating room with 3D echo. Why do you don't do that?
Now, because you cannot measure coaptation in commissural areas. It's very difficult to measure how much they are coapting in commissural area. Coaptation, when you measure, is really A2, P2. As you move to the lateral aspect, it's 2 or 3 millimeters only. Centrally, you can make 1 centimeter if you like coaptation. We like to have enough coaptation, but it's not as important, I don't think, as in the aortic valve, where the structure is so much smaller, and coaptation is so crucial for long-term outcome aortic valve repair, which in mitral valve, the mitral valve doesn't change very much. So as long as there is no prolapse, and all segments are inside the ventricle, we think is a reasonable result.
I'm sorry.
In other words, I don't go back for a second pump run because I don't see 5 or 6 millimeter coaptation.
But it's important, I think so.
Well, yeah, it's important, but it is voodoo, guys. You don't go back on the heart-lung machine because it was 3 millimeters and the valves function normally. So whenever I hear that, that's a goal it is a goal, but I agree with your question. I like your question, but where to find that is in the operating room. Mark the valve, look what's below the closure line with saline, close indentations in a closure line, and correct tendency to prolapse. If you have a fat lip but the valve doesn't leak, tuck it down in the ventricle. So I think you're absolutely correct.
We always use the blue toluidine to
that ink test or just marking segments with ink is the best way, I think, to get your depth of closure symmetric. It's hard. Once you're off bypass, you're not going back on if you're not leaking.
Jibrin brought up a very important point. If you're operating a fibroelastic deficiency, a tiny mitral valve, until leaf is 20 millimeter, you cannot expect 1 centimeter coaptation.
Of course not. The normal valve has
Barlow's with 4 centimeter anterior leaflet, it's going to have 2 centimeter of coaptation.
So that's why I never drink that Kool-Aid about these, depths as a marker of quality. You have a point? Bill, is that you up back there?
Yeah. Bill Northrop from Atlanta. In the new ACC-HA guidelines, the definition of an expert repair surgeon is a 95% repair rate, and everybody up on the panel qualifies. But we've heard also from Juan, we've heard from Tyrone, we've heard from Randy Martin that repair rates, generally speaking, are far below that number. How are we going to close the gap? Because if we aren't repairing degenerative mitral valve disease in patients who otherwise would have a normal life expectancy and end up with a replacement, we've doomed them to a shortened life expectancy, which to me creates an ethical problem. How are we going to solve this problem?
Socialized healthcare system.
Manuel?
I think it's already improving. You know, even the statistics that came from Dr. Adams' paper on the UK, if you compared it to 10 years ago, it would be much better. And I think that our colleagues across the world are realizing that not only it can be repaired, but that in the long term the results are much better than valve replacement, and it becomes almost an obligation to repair those valves, and you see more and more cardiologists referring to specialized centers. I think naturally we'll evolve to that. Maybe we'll never get to 100%, but it's improving everywhere.
Pedro?
You know, in the congenital world, replacement is far more common than repair. So we have an even bigger problem in the congenital. But the thing that's making the biggest difference is standardization of repair. The idea that you have a plan for anterior leaflet, a plan for the posterior leaflet, I think that's going to make the difference as far as surgeons being able to accept these. In the days when we had 5 different ways to treat anterior leaflet prolapse, and some of them were very, very technically challenged and not reproducible, then the results were unpredictable. Now I think you've got much more standardized ways to manage these things.
Fernando?
Yeah. Well, here in Brazil, according to the last national database, we do less than 20% of the repairs in mitral valve disease
not
in
from
Brazil.
insufficiency.
No,
all
in general,
valves.
in general. And most of the cases, of course, in Brazil are rheumatic.
Yeah.
As we have 2 very experts in the table, Dr. Antunes and Dr. Elcuri, I'd like to ask them about what the expectation regarding the long-term results, like the degenerative, if it's possible, and what's the trick to have so good long-term results?
Well, Jabrin has presented at the second level of rheumatic valves. Those are mean age of 50, 55 years old. They have a rheumatic process is stabilized. It's different from what you're talking about from Brazil. I just returned from Mozambique, where I repaired mitral valves in 18 young patients aged from 8 to 17 years of age. There, if you take I say good 5 years, excellent 10 years. You bring them from the age of 12 to the age of 18, and then maybe you'll need to replace. It's important. We have that experience together in Recife. So rheumatic is a very large spectrum of pathology, and you'll have to have that in mind. But again, in Portugal, in Coimbra, for all our rheumatic patients, they have been published about 2,000 rheumatic patients, the repair rate was 85%. But for patients who came from the Portuguese ex-colonies in Africa, where we need really to repair, we have repaired 100% of the cases. I mean, exactly what the environment of the patient, what you think that will happen if you put in a prosthesis on those patients. You can't use a bioprosthesis. It will degenerate fast, and you can't use a mechanical prosthesis that don't take the anticoagulation. So sometimes you are obliged to have a less than perfect immediate and medium or long-term result, but still believe that for that particular patient is better if you do that. Okay.
You have a comment?
Juan Amaya from Colombia again. I totally agree with what Fernando said. We did a survey amongst cardiac surgeons in Colombia, and the repair rate was 20% as well. Now, I think that the idea that in Latin America we see a lot of rheumatic valve disease, mitral valve disease, is very much a myth. It depends on where you are in the country. I know Brazil has a higher incidence of rheumatic heart disease in the north, not so much in the south. The same applies to Colombia, where if you take the incidence of rheumatic heart disease as a whole, it probably does not exceed 25 to 30%. So we're not repairing valves because we're not trained, or because surgeons are not trained to do that. And I think that something like the Master of Heart Valve Repair that I believe was very, very useful in Europe to bring repair rates up is something that would be an interesting initiative from something like the ATS and Edwards through the Every Heartbeat Matters. Just to answer Bill's question, but I don't believe that thinking that we see a lot of rheumatic heart disease is the excuse not to repair valves.
Yeah, thank you very much for your comment. I think we see the same thing in the United States. If you look at the age of 75, it's one of the strongest predictors of replacement. It has nothing to do with pathology. You have a little piece of calcium, it's rheumatic. Of course, it's not rheumatic in a 75-year-old. So you're absolutely right that we need to define the repair rate by etiology. And Bill, it's not that you have to have a 95% repair rate to be an expert surgeon. It's for that patient without pathology, you have a you think your chances of a repair are 95%. So the patients Jabreen showed, they're not 95% repair patients. Even in our hands, they're not. So it really depends on what we see in the pathology. A couple of quick questions before we get a cup of coffee. The first one is patch augmentation. So the two questions are, one is, Jabreen, I love the idea of segmental patch augmentation posteriorly. I think that's very clever. No matter how much I follow the rules, we occasionally get the cusp effect posteriorly and have functional stenosis when you use a single patch. I learned something there, but we didn't talk about the material. And I'm curious, Pedro, but Jabreen, you guys tell us what material you're currently using for patch augmentation. And my second question is, why weren't you showing anterior patch augmentation? You were showing replacement where you cut out calcification, and I've started to drop the anterior leaflet much more, going behind the commissures and trying to drop the anterior leaflet. I focus more on anterior leaflet augmentation versus posterior augmentation. So how about you guys comment on these 2 points?
For the anterior augmentation, I mean, it's a question of material. Because we don't have yet the ideal material, I try to avoid augmenting the anterior leaflet. I try to have really a normal, let's say, anterior leaflet in terms of quality and the quantity, and if I have to augment, I'll do it on the posterior. And I do it on the posterior, but I found, as you said, that if we use one patch, it doesn't move. So for why I'm trying to do scalloped, I mean anterior posterior patch in order to have more motion, and it is I tried in the pediatric, and it's quite helpful. Now, for the material itself, now what I am using now since the 2 months is CardioCell, is the cellularized pericardial patch. We will see, but I mean usually I try to use any material.
Yeah,
because
Pedro?
it is on the posterior. Because it is on the posterior, even it calcify. I mean, the functioning is on the anterior.
You mean you are running away from the patient's own pericardium?
No. I mean I use all, but I mean sometimes.
And if you use patient's own pericardium, do you treat it with glutaraldehyde or not? Because people are going back to fresh pericardium.
Yeah, I'm more and more going to fresh, mainly because it's a small area. If you want to use a big patch, it's easier technically to treat it with glutaraldehyde because it's much easier to work with it.
Pedro?
In children, we tend to use more autologous pericardium. We went through a phase where we didn't treat with glutaraldehyde, and it actually shrank faster. Yeah. So now we treat but 5 minutes in glutaraldehyde, just dip and come out. And that so far is still the best. We've tried, I'm going to talk about this afternoon, we tried Core Matrix, we tried CardioCell, we've tried everything under the sun. Right now we're testing PhotoFix, which is a light-activated cross-link. We studied them, we looked at the pathology, they all calcify. They're some a little faster than others. I don't find the difference.
That's a good reason for avoiding anterior leaflet augmentation?
Well, in congenital...
If you have a posterior leaflet augmentation and it calcified, it still works
it's not
as
a
a
problem.
wall.
Yeah, it's less of a problem. But the problem that you find in congenital, especially when you're dealing with a canal defect, you have deficiency of that anterior leaflet. And so you have to often augment it, and you're stuck.
I think I have the idea now, or the hypothesis that if we have a moving leaflet, will calcify less than a really stable one, or So for why the idea to do scallop patching, make the valve mobile, maybe the durability or the calcification will come later on.
Okay, so I have one last question, then I'll turn it over to the floor for the very last question. My question to the panel is, how many times does sliding plasty still a relevant technique? I go to meetings, we never touch the annulus. So who here has stopped touching the annulus in degenerative disease?
I do.
You do?
I've done that, yeah. Well, instead of doing quadrangular resection, you do a triangular and you fold the posterior leaflet and you avoid touching the annulus, especially because of the circumflex artery. Is also
Jibreen?
I systematically do slides, nearly
Yeah,
systematically.
me
sliding
too.
plasty.
So one against Tyrone, you're the tiebreaker. You do sliding plasty, you detach the posterior leaflet still?
Yes, I do.
Okay. The last question.
Okay, Francisco Costa from Curitiba. Just going back to the patch material, I think one material which will be very useful is decellularized human pericardium. We're going to show some of our data on decellularized human tissues. The most striking feature, it does not calcify even in the long term and even in the kids. So I think Manuel was in Curitiba. I think he used one of those patches that has good consistency, very pliable, and very promising.
Yeah, that certainly is the final chapter for rheumatic repair. We needed a tissue we could augment or do sort of hemivalve replacement in. So that'll be interesting to follow. I want to thank all the speakers. Thank everyone for staying. We'll go get a cup of coffee and see you back in about 20 minutes.